Okay, I think we're going to get started. Thank you. Today I have the pleasure of introducing Matt Rivera from the Division of Nephrology and the Kidney Research Institute. I'm encouraged to see that we're having more and more talks from outside the division focusing on the major Framingham risk factors, which we've farmed out to other divisions over the past 50 years. And today, Matt is going to be talking to us about ambulatory blood pressure management in the resistant hypertension population. Matt was born in Tennessee. He stayed on the East Coast for a number of years, going to Yale, where he got a degree in the history of medicine, then went to Harvard Medical School, and thereafter to Mass General Hospital, where he did his residency. Then came out west to do his fellowship at University of Washington in nephrology and a research fellowship. He's been on the faculty since 2017, and he's already achieved the distinction of running the hypertension clinic. He was Teacher of the Year for Nephrology in 2018 and has published widely on the subjects of tolerance of dialysis and quality of life in dialysis patients. He has 28 peer-reviewed publications, half of which are first author. So please join me in welcoming Matt Rivera for us. Grand.
All right. Well, thanks so much, everyone, for having me. Thanks, Ted, for that nice introduction. So it's a pleasure to be here on what I hear is your last cardiology grand rounds of the season. So thanks, everyone, for coming. So Dr. Roth asked me to speak today about the topics of ambulatory blood pressure monitoring and resistant hypertension. So I've combined them, and hopefully you'll find this interesting. We'll have time for questions at the end. This is my disclosure slide. All right, so just as a brief outline of what we'll talk about today, I'll spend some time giving you all an overview of ambulatory blood pressure monitoring. I think most of you are very familiar with this, but I want to get everyone on the same page, and then also talk about what the data is around ambulatory blood pressure monitoring for risk stratification of all patients with hypertension. I'll then talk a little bit about the use specifically of ambulatory blood pressure monitoring, or ABPM, in prognosticating and risk stratifying patients specifically with resistant hypertension. And then finally, I'll talk about the use of ABPM in actually monitoring response to treatment in patients with resistant hypertension. So just, as background, you all know that this really is a dizzying time for the evaluation and management of hypertension, at least here in this country. Just a few years ago, the most recent clinical practice guidelines were really from the sort of defunct JNC8 panel that recommended blood pressure be controlled to less than 140/90 for most people and even less than 150/90. And then in 2017, you had really almost simultaneously the release of the ACC/AHA guidelines for the management of hypertension, and also the American Diabetes Association released similar guidelines, really lowering targets and thresholds for treatment down to really 130/80 for most individuals. The European Society of Cardiology and Hypertension followed a year later with really similar guidelines. So really this has been a paradigm shift and being more aggressive about blood pressure management in most patients with hypertension. And so what's happened? Well, what's happened is nearly overnight in 2017, as you can see in the left column here, an additional 31 million individuals suddenly had a diagnosis of hypertension. And of these individuals, an additional 4 million had a recommendation to immediately start pharmacologic management for hypertension. And among patients already on treatment, an additional 8 million immediately were felt to be suboptimally controlled. Now, the population of patients, prevalent patients with resistant hypertension also grew, although to a somewhat more modest degree. So resistant hypertension is classically defined, although not everyone agrees, but classically defined as a patient with uncontrolled blood pressure on 3 or more medications of different classes in a rational combination. Usually one of them should be a diuretic, or any patient with even controlled blood pressure on 4 or more medications. So we think that overall there's about 103 million adults in the United States with hypertension. Of those individuals, using guidelines prior to 2017, probably about 18 million individuals meet criteria for resistant hypertension based on what I've just said. With the newer guidelines published in 2017, probably an additional 2 or 3 million people would meet criteria for resistant hypertension. Now, the rate of true resistant hypertension, really eliminating individuals that have medication adherence issues, it's been a little bit of a challenge to estimate what that population is. But even if we take the upper range of what's been estimated for non-adherence, around 40% of individuals are non-adherent in some capacity. You have at least 12 to 15 million people with resistant hypertension in the United States. And this population provides a large pool of referrals to subspecialists and hypertension experts, including cardiologists, nephrologists, some endocrinologists in some parts of the country. And I think one of the major tools that we can use to hopefully improve prognostication and management of these patients is ambulatory blood pressure monitoring. So what is that? Well, in its simplest form, ambulatory blood pressure monitoring is the use of a device that a patient would wear for at least 24 hours, as long as 72 hours. And this device would take blood pressures in an automated fashion without any intervention from the patient themselves, usually between every 15 and 20 minutes during the day, and every 15 to 60 minutes overnight, depending on what the provider orders. And importantly, the patient is not shown feedback about what the blood pressures are. Now, 20 years ago, ambulatory blood pressure monitors weighed 5 pounds, were very clunky. But now, really, the newest devices, of which I've shown an example here, this is the Space Labs OnTrack device, which is the newest device we use here at UW Medical Center at Harborview in the hypertension clinic. They weigh like less than a pound, and they last many days on 2 AA batteries. They have a touch screen that allows it to be easily programmed even without a computer. And as you can see by this very comfortable looking gentleman here reading a newspaper, most patients tolerate this reasonably well. Now, there are some exceptions to that, particularly individuals with particularly severe hypertension where the inflation pressure on the cuff has to repeatedly go quite high. Some people can find it uncomfortable and can even get bruising around the arm over the 24-hour period. I used to be concerned people would wake up all the time at night with this, but in general, that hasn't been a major complaint that I've found. People generally sleep after the first time it goes off at night. And it generates beautiful looking reports like this one here on the right, where you're going to get, first of all, a graphical display of not only blood pressure, but heart rate throughout the day. You'll get an average of the daytime period, whatever you said is the nighttime period, and then a 24-hour average. In addition, you'll get the degree of blood pressure variability. And importantly, something we'll come back to later, you'll get the degree to which the blood pressure is lower overnight. So we know from many cross-sectional observational studies that blood pressure goes down at night due to a variety of circadian-related, usually hormone release patterns from cortisol, some catecholamines. And in general, the average dipping pattern overnight is by about 15 up to 20%. In individuals who have a decrease in their blood pressure of less than 10% at night, they're usually given a label of being a so-called non-dipper, and we'll come back to that. But what should the ambulatory blood pressure actually be? So we know what I've just told you is that blood pressure goes down at night. So if you average over the 24-hour period, any given daytime clinic blood pressure is going to correspond to a lower 24-hour average pressure. And it turns out that this difference grows as overall blood pressures go up. So the table that I've shown here is from the most recent 2017 ACC/AHA guidelines that suggests that, for instance, if your office blood pressure is 130/80, even if someone does not have significant white coat effect, which we'll get back to, their 24-hour ambulatory blood pressure is about 125/75. If, on the other hand, you have a patient who has an office blood pressure of 160/100, that's going to correspond to a 24-hour ambulatory blood pressure of 145/90. And this happens for 2 reasons. 1, again, the nocturnal dipping pattern, and 2, pretty much everyone has some white coat effect. We'll get back to that. And before I go on to some of the data, you get more than just the numbers, of course, with the ambulatory blood pressure monitoring. You can then classify patients into different phenotypes depending on their ambulatory blood pressure and their clinic blood pressure. So you can have patients who, for instance, are normotensive using both blood pressure measurement techniques, patients that have sustained hypertension who are hypertensive in clinic and using ABPM, and then you have two discordant phenotypes. You have a patient who is hypertensive in the clinic, but doing 24-hour ABPM, they're normotensive. That would be labeled as a white coat hypertension. And if the patient is on 3 or more medications, that's going to be a white coat resistant hypertension. Patients who have elevated blood pressures at home using ABPM but are normotensive in the clinic would be labeled as masked hypertension. And if they're on 3 or more medications, that would be masked resistant hypertension. And we'll come back to those phenotypes. So what really is the point of gathering all this data, other than the fact that we as doctors like data, especially me as a nephrologist? Well, in the 1990s and early 2000s, there was a series of observational studies showing that in untreated patients, after controlling for clinic blood pressure, ambulatory blood pressure was a great predictor of adverse cardiovascular outcomes. But then in 2003, this sort of landmark study was published in the New England Journal of Medicine called the Office versus Ambulatory Pressure Study that took treated patients with hypertension, not necessarily resistant hypertension, which we'll get to, but all patients with hypertension, 1,900 patients, all had clinic evaluation and ambulatory blood pressure at the beginning of the study and were followed forward for a median of 5 years. And the major findings I put here in the table 3 from the paper. These are relative risks associated with a 1 standard deviation increase in blood pressure, which was about 8 millimeters of mercury. And these blood pressures were adjusted for clinic blood pressure. So this is given the same clinic blood pressure if you have an 8 millimeter of mercury higher ambulatory blood pressure, your risk of fatal or non-fatal cardiovascular event went up by 34%. All right. And then there was not an effect on mortality, but certainly the cardiovascular events were affected. So this raised the specter of a real value to ambulatory blood pressure monitoring. And the preliminary results from this study led CMS to actually endorse payment for ambulatory blood pressure monitoring to physicians. We'll get back to that as well, because it's insufficient. Fast forward about 15 years, some of you may have read the paper published just last year in the New England Journal from this large Spanish hypertension registry, where over 60,000 patients got ambulatory blood pressure monitoring. And this is like a data warehouse here. It's amazing. I wish we could have this many people getting ABPM in the United States. And all these patients got ABPM at baseline, followed forward again for 5 years, this time for all-cause and cardiovascular mortality. Again, the data was adjusted for clinic blood pressures, and clinic blood pressures were adjusted for ambulatory blood pressures. So the main result is here, I've reproduced in this table, which shows that in an individual for the same clinic blood pressure, a 24-hour systolic blood pressure that is 1 standard deviation higher, in this case 10 millimeters of mercury, was associated with a 58% increased risk of adverse outcomes, in this case, mortality. In contrast, if you just take the clinic blood pressure and you adjust it for their ABPM-derived blood pressure, there's no prognostic value. But this study went 1 step further and classified people according to the blood pressure phenotypes that I've already mentioned, the masked hypertension, white coat hypertension, and then sustained and controlled hypertension. The data was interesting in that what previously was felt to be a very benign condition, white coat hypertension, was in this study associated with a 79% increased risk of all-cause and cardiovascular mortality over the study follow-up. But only if you weren't treated with medications at baseline. If you were a treated patient and you had a major white coat effect, your outcomes were the same as if you were normotensive. Now this was curious. A lot of controversy around this, a lot of discussion, and ultimately people feel like probably what's going on is that if you're untreated with white coat hypertension, you probably have an increased risk of developing true sustained hypertension over follow-up that's just not picked up, and so you have a period of untreated hypertension. But masked hypertension, right, those patients that are normotensive in clinic and hypertensive using ABPM had the worst outcomes of anyone here. So in response to this and other studies, the 2017 ACC/AHA guidelines for hypertension really endorsed a number of new recommendations that mentioned both home blood pressure monitoring and specifically ambulatory blood pressure monitoring. So most of these are grade 2 recommendations. I've listed some of them here just for curiosity's sake. I put in bold the recommendations that specifically call out ambulatory blood pressure monitoring as being valuable above and beyond patients monitoring their own blood pressures at home. So the first is that in adults being treated for hypertension with office blood pressure readings not at goal and home blood pressure readings suggestive of a white coat effect, you should do ABPM, or at least it could be useful. And similarly, the last recommendation here, if you're worried about a masked hypertensive state, then ambulatory blood pressure monitoring could be considered. I would say this is relatively faint praise for ABPM based on the data, but this is at least a movement in the right direction, I think. But despite these recommendations, what is clear is that the rate of use of ambulatory blood pressure monitoring in the United States is extremely low. So we don't really have overall prevalence numbers for the whole population, but we do have good data from Medicare using Medicare claims data. This is a paper from 2015. They looked over a 4-year period, and only 0.1% of all Medicare beneficiaries received a claim for ambulatory blood pressure monitoring. There's 60 million people eligible for Medicare, adults, and only 60,000 people got ambulatory blood pressure monitoring when probably half or more of these patients are hypertensive. So at least part of this limitation has to do with reimbursement. So I told you that in 2001, CMS approved reimbursement for ambulatory blood pressure monitoring, but it turns out that they improved it only for one very specific indication, the ICD-9 code 796.2, elevated blood pressure without a diagnosis of hypertension. So if you were treated with medications and you had hypertension, you are not supposed to use this code and Medicare is not supposed to pay for it. Any other indication is unreimbursable under Medicare, and most commercial insurances have followed suit with this. Additionally, the average reimbursement when it does get paid for is $52. The devices cost about $5,000, and there's nursing time to get it connected, physician time. So as you imagine, these devices are not widely available in the community. They're typically available in academic centers and specialty hypertension centers where these can be done repeatedly in high volume to make it worthwhile. Now, I will note that just 2 months ago, CMS, for the first time in 18 years, released a proposed revision of the coverage determination for ABPM, supporting reimbursement for ruling out masked hypertension. So that's one additional indication. It's a movement in the right direction, but still have a long way to go on that front. All right. So I'm going to move on to talk about ambulatory blood pressure monitoring, specifically in resistant hypertension. Now, despite non-reimbursement or at least under-reimbursement by CMS, most clinical practice guidelines, specialty societies, and hypertension experts feel that there are multiple benefits of the application of ABPM to the resistant hypertension population. I've listed just a few here. Certainly, risk stratification and prognosis amongst this high-risk population, detection of the white coat and masked effect, which we've talked about, we'll talk about more. I'll mention briefly this idea of chronotherapy, the idea of timing blood pressure medications differently in the day without overall intensification of therapy may actually improve outcomes. And then one thing we won't talk about today, but I will just mention now, is that ambulatory blood pressure patterns can provide some clues for certain secondary causes of hypertension, such as, for example, the extremely rare but often board-tested pheochromocytoma. So what is the data around risk stratification and resistant hypertension? Well, in contrast to that recent, very large Spanish registry study of 60,000 patients published last year, the data for the resistant hypertension population is much more sparse. So there's not a whole lot of data. This is one of the best studies that was published in 2008 in what's now JAMA Internal Medicine. This was a study in Brazil, 556 patients with resistant hypertension. They specifically defined as on uncontrolled blood pressure on 3 or more medications, including a diuretic. Patients got baseline ambulatory blood pressure monitoring, were followed up for 5 years. The primary outcome was very similar to some of the studies we've already talked about, a composite of fatal and non-fatal cardiovascular events. So this is really their kind of part of their initial table 1 that I've reproduced here, showing that amongst patients who had an outcome versus no outcome, the office systolic blood pressure was highly elevated, 177 to 180 in both groups. Additionally, the other thing to take away from this is that there is an enormous white coat effect in these patients. If you compare the office systolic blood pressure to their 24-hour mean systolic blood pressure, the difference is like 40 millimeters of mercury. So what about outcomes? Well, this is reproduced from their outcomes table. So just as in previous studies, the hazard ratios reflect a standard deviation increase in ambulatory blood pressure, in this case about 20 millimeters of mercury because you have a resistant hypertension population. And 24-hour mean systolic blood pressure when adjusted for clinic blood pressure was associated with a 32% increased risk of adverse outcomes. In contrast, just as in previous studies, this office systolic blood pressure when adjusted for the ABPM-derived blood pressures was not significant. So similar findings here from the large Spanish study I spoke about, this time in the resistant hypertension population alone. But of course, we've talked about how ABPM can give you a lot more data than just the numbers. It gives you these phenotypes when you combine the data with information from clinic blood pressures. So we've talked about the white coat resistant hypertension population, an individual that has an elevated blood pressure in clinic and a normal ambulatory blood pressure. The masked resistant hypertensive patient, the opposite discordant findings, and then the true and controlled resistant hypertensive populations, those with concordant findings. I think that white coat resistant hypertension is an especially important entity, because I think that numerous observational studies will suggest that if anything, the white coat effect is much more prominent, more common in the resistant hypertensive population, and also much more significant in terms of the numbers of millimeters of mercury that is different. So this is a study from 2003, 286 patients with uncontrolled resistant hypertension underwent ambulatory blood pressure for 24 hours, and then they defined white coat resistant hypertension as the 24-hour average of less than 135/85. So the first thing just to note is that if you look at the numbers up here, out of the total population, 44% of all patients were designated as white coat resistant hypertension. A very large number, at least 15% greater than what's found in the general hypertensive population. Additionally, if you compare the office systolic blood pressures with the 24-hour mean systolic blood pressure from the ABPM for the white coat resistant patients, the difference is nearly 50 millimeters of mercury, a giant effect. Another study published about 10 years later, this time from the same Spanish group, found that they took 14,000 patients with resistant hypertension, all of whom got ambulatory blood pressure monitors and followed them forward, and they compared them to patients who were hypertensive on 3 or fewer medications, so the non-resistant population, and they just looked at the difference between office and ambulatory blood pressures. So if you look at, for instance, the 24-hour average here in these two columns, the difference for the resistant hypertensive population was 20 to 25 millimeters of mercury compared to 5 millimeters of mercury for the non-resistant hypertensive patients. And at least one study has done, again, what the Spanish registry study did, and tried to classify patients into these resistant hypertension phenotypes, and then followed them forward to look at the incidence of adverse outcomes. This was an Italian study, an Italian hypertensive registry, 486 patients with resistant hypertension. They underwent ABPM at baseline. They were classified into these different phenotypes. So what they've labeled here as false resistant hypertension, that's your white coat resistant hypertension. Masked, we all know what that is, and then true resistant, this is an individual with uncontrolled blood pressure on both ambulatory blood pressure monitoring and in clinic. And you can see that over a 10-year follow-up period, the event-free survival for those with sustained hypertension was only 60%. White coat resistant hypertension in responders, so normal intensive individuals, had the same response, about a 90% 10-year event-free survival rate. with masked hypertension somewhere in the middle. And after adjustment for potential confounders as well as clinic blood pressures, you can see that the white coat resistant hypertension population does not seem to have an increased risk of adverse outcomes relative to normotensive individuals, but certainly the masked and uncontrolled individuals have poor outcomes. As a side note, the clinic systolic blood pressure, once again, after controlling for their ambulatory blood pressure, was not significant. Now, beyond classifying patients into these different phenotypes, I've also mentioned that ABPM gives you information about the degree to which patient blood pressure drops overnight, the so-called dipping pattern. And this idea of a dipping pattern was proposed like 30 years ago for all patients with hypertension. And the proposal was that, again, if you have a dipping percentage of less than 10%, that this is associated with poor outcomes. And this has been shown time after time in the general hypertensive population, has been associated with outcomes including LVH, incidence of ischemic cardiovascular events, etc. There's been much less data in the resistant hypertension population, but there is this one study that was done about 10 years ago now. Again, this was a Brazilian group. They followed 556 patients forward in time, and they classified patients in 4 categories. There was what they called an extreme dipper, someone that would dip more than 20% overnight. A normal dipper, someone between a 10 and 20% dip. A non-dipper, those people that had no change in their blood pressure at night. And then a so-called riser, people that have an increase in their blood pressure overnight. And they found that this non-dipping pattern, even after adjustment for their actual blood pressure, was an independent predictor of adverse outcomes. So if you were a non-dipper, you had a 74% increased risk of adverse outcomes over 5 years. So just in the final few minutes, I'm going to describe the use of ambulatory blood pressure monitoring in monitoring the treatment response of patients with resistant hypertension. So a major challenge in the management of patients with resistant hypertension who have a substantial white coat effect, which I've told you is like half of all patients, is that if you use the clinic blood pressures to target treatment thresholds, you have a major risk of intensifying therapy and dropping home blood pressures into a range where you could cause kidney injury and orthostatic symptoms. If, however, you are not repeatedly looking at home blood pressures using ABPM or another strategy, you run the risk of the patient developing sustained hypertension without you knowing. So there is a number of investigators have looked at what is the incidence of development of true sustained hypertension in people who are initially diagnosed with white coat resistant hypertension. So this is all in the resistant hypertension population. So this group, they took 198 individuals with resistant hypertension who are classified as white coat resistant hypertension, so normal ambulatory blood pressures, high in clinic. They then repeated the ambulatory blood pressure at 3 months, 6 months later, and then 6 months after that. So over a 15-month period, you would get 4 of these things done. And at the end of that, only like 33% of the initial group continued to have a diagnosis of white coat resistant hypertension. Everyone else had developed sustained hypertension. And then when they looked at what are the predictors of people continuing to have only a white coat effect and not having developed true sustained resistant hypertension, the only significant predictor is that if your daytime average on the ABPM was really low, like less than 115. So this group has proposed this extremely aggressive algorithm for how frequently you should do ABPM in the resistant hypertensive population. No one is doing this, and I don't suggest that we all do this, but it is interesting. They would state that once you've diagnosed a patient with white coat resistant hypertension, you should repeat the ABPM in 3 months. If it confirms white coat resistant hypertension, you repeat it again in 6 months and then yearly. And for every patient with even controlled resistant hypertension, they would advocate repeating ABPM annually. Now, this is impossible, right, in the context of current available resources in the United States. Even at dedicated hypertension centers, this would be kind of beyond the scope of what I think we can do. We've got 4 monitors at Harborview Hypertension Clinic. But I think it is thought-provoking about really what we should be doing in this country. And then finally, what about this idea of chronotherapy, right? The idea of timing medications at different times of the day to try to achieve better outcomes for our patients. So there's been a number of investigators, mostly in Europe, that have been really interested in this concept. This is an example, a randomized trial of 250 patients with uncontrolled resistant hypertension at a single center in Spain. All patients were on 3 medications, mostly in a rational combination. They had some patients on alpha blockers. This was the pre-all-hat. And they randomized patients to moving 1 medication to the nighttime or taking all of them in the morning. They then did ABPM at baseline in 3 months. So the baseline results are here, where you can see this second dip here is during the nighttime period and is only about 3 or 4 millimeters of mercury. So this would be less than a 10% dip, so an absent nocturnal dipping pattern. And then 3 months later, in the patients who had moved 1 medication to the evening, that's this dashed line here, you see a dramatic restoration of the nocturnal dipping pattern. And then in the graphs on the bottom, without intensifying therapy, just moving 1 medication to the evening, you actually got an improvement in the 24-hour mean blood pressure of 9 or 10 millimeters of mercury. Again, a single center study, but thought-provoking. Perhaps even more controversial would be this follow-up study that they did, a randomized trial, where they looked actually at cardiovascular outcomes, where their paper suggests a 60% benefit in preventing adverse outcomes from moving 1 medication to the nighttime dosing period. Now, this is not believable, I don't think, but it is interesting and I think argues for more research around the idea of timing of medication dosing as a way to spare patients from intensification. So just some key points. So, I believe that ambulatory blood pressure is a powerful tool for the evaluation management of patients with resistant hypertension. Hopefully, I've started to convince you of that. There's multiple potential benefits assessing for white coat and masked effects in this population, assessing for diurnal variation, assessing the response to treatment. I think clinical trials are really needed, however, where ambulatory blood pressure monitor derived blood pressures are used as either exposures or outcomes. So it's important to note that no large hypertensive trial published recently has used ABPM derived blood pressures as the outcome of interest, or the exposure. So SPRINT trial used automated office blood pressures, not ABPMs. And additionally, I think studies are really needed to test what we all think, which is that whether the addition of ambulatory blood pressure monitoring to classically derived either home or office-based blood pressures actually improves outcomes for patients, or is it just generating a lot of data for us as clinicians? So I'll stop there and then can take any questions you might have.
There were some falls of people who have been treated and had low blood pressures at night. And you've not presented any data at all on the cold disease, and including diabetes medics. I wondered if you could say a few words about that.
Yeah, I mean, I think that is hopefully one of the reasons to do ambulatory blood pressure monitoring would be to prevent overtreatment of a patient who has an intense white coat effect. So hopefully we'd be preventing some of those adverse outcomes, but I'm not sure I'm getting at your exact question. At night. I'm actually not sure of that information. I don't know. We certainly know that from data from, for instance, the SPRINT trial, that patients that were aggressively treated to lower automated office blood pressures, which have been correlated to some extent with ABPM, did have an increased risk of outcomes such as falls, hyperkalemia, and acute kidney injury. But when you look overall at what would be considered a hard outcome, although you could argue that fall is a very important outcome from elderly folks, there didn't seem to be an increased risk for those patients. So in like my community, for instance, we have really started to accept more acute kidney injury in patients treated aggressively for hypertension, because it looks like that is still associated with good outcomes over the long term. But I don't know the exact data for falls. I think that's a really good question.
So I think, so one question I have was great talk is this whole concept of resistant hypertension.
Yeah.
Because how common is it? Because there have been studies that have looked at, and you could do things like pill counts or prescription results, but even if you look at like urine liquid chromatography of the patients actually take their medicines, most people with resistant hypertension just aren't taking their medicines. So how do you account for that these days? How do you even know if these people really are resistant or if they're just not taking their medicine?
Yeah, it's a good question. The studies that I've quoted have not done like confirmatory LCMS to figure out what metabolites are actually in people's blood. Certainly, this has been done with all patients with hypertension, and you're correct that depending on the study, the rate of complete non-adherence is anywhere between 30 to 60% of all patients aren't taking any medications. And up to 60 to sometimes 70% of patients are only taking some of the medications. So it's hard in the clinical trials to really get at that, unless you're going to be doing mass spectrometry on everyone. But I think it's a real concern. But it's difficult to know how to get around that. I think figuring out ways to better ensure adherence is extremely important, but a real challenge.
Yeah, so on a practical level,
Yeah.
can we order an ABPM here at UWMC, and should we be ordering ABPMs? And in that case, on whom?
Right.
And or should we just kind of sit back, as you suggested, and wait for trials to show that it actually is beneficial?
Yeah, so I guess your second question, so I don't think that we should just sit back, because I think that there is enough observational data that to me is compelling that for certain patients, we should do this. And I think for all of us who see patients with resistant hypertension as secondary referrals, I do think it can be really valuable to establish a baseline and then assess response to treatment because of the, as I've mentioned, the very high prevalence of white coat effect and mast effects in these patients. The practical aspects are challenging. So right now at Harborview, there is no way to order, for a primary care provider, for example, to order an ambulatory blood pressure monitor. In the hypertension clinic, we have 4 monitors. I've heard that you guys just got 2. And these are really being used for patients in my clinic that are referred for complex or resistant hypertension. And for you all, you're using for your own patients. Are you offering it as a standalone service?
Yeah.
You are.
And it's actually, we have it ordered and monitored and followed up by our pharmacist,
Okay.
clinic pharmacist.
So that's 2 monitors, at least, that are available for other folks to order. Here at UW Medical Center, I don't work here, but I'm pretty sure that it is offered as a standalone service through cardiology here. I'm not sure how many monitors are available. But you have to, when you're putting in the order, you have to check off all the boxes that say this is a patient that doesn't have a diagnosis of hypertension, that has 3 blood pressures that are above goal in clinic and 2 at home that are below goal. And if you don't meet all those criteria, you're not supposedly supposed to order it because it's an unreimbursable service. So I do a lot of them in my clinic. We don't order or bill for them. We just do them as part of the service. But hopefully with more indications for reimbursement, these will become more common even in primary care practices. And so providers could be ordering their own. But I think it's a real challenge logistically.
Practically speaking,
Yeah.
give me an example of a patient I might see in cardiology clinic on whom I should order an ABPM.
Right. So I would order an ABPM on a patient that you see if they're very hypertensive, if they have resistant hypertension and you're seeing them, and they're reporting any blood pressures in any environment that are lower. So yes. So if you're concerned about a real white coat effect, so you don't want to drive their actual home blood pressures lower by intensifying their therapy. Conversely, if you're seeing a patient that has controlled resistant hypertension and you're seeing them in clinic and they're saying, I checked my home blood pressure and it's 180, then you really do run the risk of missing a masked hypertension, which, as I've shown, is really associated with poor outcomes. Now, again, no trials suggesting that, treating or targeting blood pressures and masked hypertension actually improves outcomes. But I think the observational data is certainly there.
It sounds like you're using home pressure remember to sort of trigger whether you get the ambulatory. And so why not just act based on the home blood pressure?
Why not act? Because there's significant concern that patients may have a white coat effect even taking their own blood pressures at home. We call it a white coat effect, but really it's like an anxiety-related effect, or it's, you know, it's almost like the Heisenberg uncertainty principle. Like if you measure the blood pressure yourself and you see the result, it's going to drive your blood pressure up. And additionally, we know from many studies that people's blood pressure technique is awful. And they take their blood pressure standing up after a jog, you know, and it's 40 millimeters of mercury higher. So I think it's really trying to establish a gold standard.
But is there any technology, for instance, people can buy these monitors for their iPhone that record their heart rhythm. Is there a technology that's developing so that a patient can actually buy an ABPM type of technology and then transmit it to their physician?
Yeah, so they're not as good or small as the ABPM devices, because basically it's going to be, you know, still the size of a monitor that you can't really wear. So it's got to be like on the bedside table, but they do have devices that connect to Bluetooth, can upload to your phone, and you can send that to your doctor. So if you have a patient like that and you've counseled them on technique and you've watched them do their technique in clinic and you're pretty sure that they're doing it right and they're showing you the log of the blood pressures, I take that, you know, so I trust that.
So my question is pretty much along the same lines. It's like, you know, why not just use the blood pressure? Because, you know, people don't eat much technique. You know,
so I would disagree with that. Yes.
Because if you do it enough times, you know, you just get like immunized to it. You know?
Yeah, so that's actually not been borne out, and that people's technique can be very difficult to correct. And yeah, I would argue that's probably a much simpler. I mean, we can barely train. Oftentimes, like our medical students and the nursing staff takes like hours to train them how to do blood pressures correctly. So I think it is more complicated than it seems at first.
Right now, if you get a whole blood pressure monitor, what does the person have to take home? What do they wear? What do they do? Can they you know, take a shower and go to sleep? I mean,
Are you talking about the ABPM devices? You can't shower with them. You can do everything else. Yeah. So it's an oscillometric device, just like your clinic blood pressure devices. It's just very small, and they've been calibrated and validated against international standards, and so you get good blood pressures. However often your doctor sets it for, which if they're cruel is every 15 minutes and otherwise is every 60 minutes. Yeah, so it does go off every 15 minutes. You mean like oscillatory or? I hope so. I hope so.
I had a question. It seems like the data is reporting mean systolic blood pressure.
Yeah.
But getting back to the question about falls in the elderly and arterial stiffness, this pulse pressure, there must be data on pulse pressure in the elderly and mean arterial pressure rather than mean systolic blood pressure. Has that told us anything?
Yeah, so, I didn't show the data on, for instance, like pulse pressure variability, overall blood pressure variability, and, all those things do also predict adverse outcomes. It turns like if you use the nocturnal versus the daytime means versus the 24-hour average, I didn't show a lot of the daytime and nighttime pressures because basically it all looks the same. All the hazard ratios look the same, but you're absolutely right. There is other ways to use the ABPM data to derive like percentage of blood pressure variability, and that is also an independent risk factor. So that's another element of the ABP report that you can look at.
If someone doesn't have a diagnosis of hypertension, and you think their blood pressure is too high anyway, say for instance, because they have congestive heart failure, has that been explored in order to decide about the impact of therapy on that?
So if you feel like you want their blood pressure
around the indication, hypertension.
Right. You're saying like if a patient has a blood pressure of 125, but you want it lower because of heart failure. Could you do this therapy? Sure. Yeah. And it turns out, so, you know, I didn't talk about it, but that Medicare data claims data paper actually showed that even all the claims that got paid for rule out white coat hypertension, 60% of those people were actually on medications for blood pressure. So Medicare is not looking, can't really say this, but Medicare is not looking all that closely at whether the patient actually has hypertension or not, for what it's worth.
Yeah, one thing that we run into is sort of a younger person with syncope or lightheadedness. We end up putting them on the tilt table, which I think would be far more expensive than just putting ambulatory blood pressure monitor on. Has anyone looked at that strategy?
So are you talking about a patient that is hypertensive or someone that has actually like hypotension, orthostatic?
Somebody comes in that's a concern for hypertension,
right,
daily life, thoughts on the POTS,
yeah.
things like that.
So you guys familiar with John Oakley here, neurologist here. So, you know, he does a lot of ABPM in his clinic, even for patients that are not hypertensive, as a part of the workup for dysautonomia along with the tilt table test. So I think there is value there as well. I don't see those patients in my clinic because they're not referred to me usually. John and I do share some patients.
You know, traditionally, cardiology's been assigned the task of being the experts in hypertension. And I think you're proving us that there's an alternative and collaboration is useful. Can you tell us what type of patient a cardiologist should refer to the hypertension clinic?
So, I think it's really whenever you feel like I can be helpful. I think that you all are experts in hypertension. In nephrology, some of us are experts in hypertension. I think it can be a collaborative relationship. I think what we put on our website and with the referral center in terms of criteria referral is I'm happy to see any patient with resistant hypertension. In addition, any patient who is younger where there's a concern for a secondary cause or inherited monogenic condition, something like that. But if you guys just want a second opinion on management of a patient that's having trouble, I'm happy to see those patients one time and then just give you a call. I'm really open. We've just started running the clinic now 6 times a month over at Harborview, so we have a little bit more capacity. And so happy to see anyone.
Thank you very much.